I want to talk about the menopause symptom that no one talks about and why it won't go away on its own. In my practice, I see a lot of menopause and perimenopausal patients, and hot flashes tend to get all the attention. And even the experience of hot flashes, patients talk about the fact that they might not even have hot flashes, even though it is purely a temperature shift or feeling hotter than you normally would. That is really a key indicator that that thermoneutral zone, that zone with which you feel comfortable in your temperature, has changed. And that's something that happens very often in perimenopause and menopause. They talk about mood swings. I see memes all over the internet. But the menopause symptom that affects up to half and probably more of postmenopausal women, and almost no one brings it up, is called genitourinary syndrome of menopause, or GSM. And so, if you've been quietly dealing with vaginal dryness, burning, painful intercourse, or recurrent urinary tract infections since perimenopause or menopause hit, you're probably dealing with GSM. And GSM is different from almost every other symptom of perimenopause and menopause. And the reason for that is because when we look at hot flashes or mood swings or any other symptom that happens in this transition, they tend to peak and then they resolve as things level out. Sleep issues often stabilize, hot flashes tend to go away, but GSM is progressive. It gets worse over time. And this is because there's a lack of estrogen in the tissue, and it's not because of hormonal fluctuations. And so what happens normally is estrogen keeps the tissue of the vagina, the vulva, and the urinary tract thick, elastic, and well lubricated. Estrogen is also part of what supports a healthy vaginal microbiome. Good bugs in the area, lactobacillus, are the main bugs. And estrogen also maintains blood flow to the area. So this can help with arousal and lubrication during intercourse. We also see estrogen maintaining a pH of the vagina, and this keeps it within a range that reduces infections, stops the overgrowth of bad bugs, and just maintains that environment where lactobacillus, the bugs that are supposed to be in the vagina, stay there. Okay. So in perimenopause, when estrogen starts fluctuating and then eventually drops, the tissue becomes more thin, less elastic, produces less natural lubrication, the pH changes, which is why there is such an increased risk for urinary tract infections and yeast infections. And this becomes progressive because ultimately, if you left this untreated without any estrogen to the tissues will eventually become firmer and less easily moved. And this is where patients experience intercourse that they can no longer have. This is where we end up having to go to pelvic floor physios and really help with dilation strategies again. And the problem is this doesn't go away on its own, and it's never talked about. You know, in my practice, patients wait years to bring it up because they don't really know what it is. And because it's so progressive, there's lots of changes that happen in midlife. We see hormonal changes, we see changes in the roles that happen. People are caring for their parents, they are raising children, their children maybe are going to university, becoming adults, and they have a lot of things on their plate. And then if we layer on, maybe their sleep's not great. Maybe because their sleep's not great, their energy's low. And maybe because their sleep's not great, their energy's low, they have hot flashes. Maybe they are more inclined to avoid intimacy with their partner. This is the time where a lot of children are becoming adults and moving out. And so it is likely if couples are going to separate, they end up separating. And so if there is already a lack of intimacy and libido issues, sometimes patients don't even notice it and they don't bring it up. And it's not until I bring it up as something that happens in perimenopause and menopause that they start to notice, oh, this is going on with me. And again, because it's slow and it's progressive, sometimes you don't notice those subtle changes that happen day to day, month to month, week to week, right? And what we know is that if we can get estrogen on those tissues sooner rather than later, you're going to have the best net benefit on your symptoms overall. And a lot of patients think that there's nothing you can do about it, or they don't really know. They don't really know that there's an option, or they don't know that vaginal estrogen can be used alongside their systemic hormone therapy. And they think that they just have to live with it. So, this is something I like to bring up in general with all of my patients because I like to open the conversation, even in my perimenopausal patients, where Maybe they're not even dealing with this at all yet. I like to bring it up so that they are aware and what to look for and what to notice. And so that you know when those symptoms arise, there is something that we can do. So few women actually talk about it. Part of it is embarrassment. Part of it is that many women assume painful intercourse or dryness is something you have to accept after menopause, so they just never mention it. And a lot of it is that appointments are short. This symptom requires a longer, more specific conversation. Maybe they have more pressing concerns. Maybe it's the hot flashes or the weight gain, or maybe they have pain, or maybe they already have medical conditions and they aren't bringing it up. Also, a lot of women I speak with don't realize that their UTIs that have just started coming out of nowhere, or their yeast infections that they never had before and are now worse all of a sudden, have nothing to do with the menopause transition. So, this is the conversation that gets left out of it specifically. And let's talk about what actually helps. So, a lot of times people will think that they just need to use more lubricant. And using more lubricant can be helpful in the time where you're going to be intimate, but it doesn't fix the root cause. It doesn't fix the local treatment that needs to happen with specifically estrogen. Now, if somebody has mild vaginal dryness and mild pain with intercourse and they've not done anything yet, vaginal moisturizers are a reasonable place to start. You can get them over the counter. A lot of them come with formulations that have things like hyaluronic acid, aloe, vitamin E. These are all reasonable things. If you have a sensitivity to some of the preservatives in some of the over the counter products, we can always get something compounded for you and you can try that. But if somebody comes to me with severe vaginal dryness, low libido, UTIs, I know that the research tells me that adding in vaginal estrogen is the first line treatment here. We know that a local vaginal estrogen has a very strong safety profile for most women, including many with a personal history of breast cancer when used under guidance. And so, especially with people who have had breast cancer or breast cancer treatments or are at high risk for breast cancer, they often don't know that this is an option that is most often available to them. Obviously, with guidance from their oncologists and other medical practitioners, it's important to have this individualized conversation. But knowing that this is an option is really, really important. We know that other things that can be done are pelvic floor physiotherapy to address muscle tension or weakness contributing to pain. We know that there's nutritional and lifestyle support to reduce inflammation and support tissue health. And again, the estrogen addresses the vaginal microbiome. So some of my patients will be using a lubricant when they are intimate because they find it helpful and beneficial. But vaginal estrogen is meant to be used, or a vaginal moisturizer is meant to be used outside of that. So typically we're dosing at kind of a loading dose where we're doing every single day for a period of 2 to 3 weeks. And then we are getting to our lowest maintenance dose, which can be anywhere from once a week to every other day. And some patients need it every day. It depends at what point we intervene, how far the tissue has gone in terms of dryness and atrophy, and how responsive the patient is. Some patients on systemic hormone therapy, if they're on an oral estrogen or a topical estrogen, they will have some resolution in their vaginal symptoms. But we also know that vaginal estrogen can be really helpful in symptoms of overactive bladder. And so in some of my patients, they have an overactive bladder that has been slightly worsened by the addition of systemic estrogen. And so adding the vaginal estrogen is actually a really big help for them in this context. So this video was just meant to bring awareness to that because painful intercourse can affect intimacy and relationships. And being uncomfortable in your own body and feeling too embarrassed to bring it up is something that happens far too often. So if you have not brought this up to your medical doctor, if you didn't know what options existed, now you do. Feel free to comment below and let me know your thoughts. And we'll see you in the next video.